Atrial fibrillation, also known as AFib or AF, is a disease which is characterized by irregular heartbeat, frequent episodes of dizziness, shortness of breath, physical or cognitive limitations, leading to disability and pronounced internal discomfort. Episodes of atrial fibrillation are often asymptomatic. As of today, over 1.5 million people in Russia suffer from this type of arrhythmia, and this is just according to the official statistics.
1.5 million people in the country have atrial fibrillation. Nobody would have even noticed if it wasn't for strokes, arrhythmia causing thrombi to be ejected from the heart. Nowadays, this is the most pressing challenge.
Aksina Kulturina, PhD, is a cardiologist in one of the leading hospitals in Moscow, Russia. It would appear that she knows everything about the heart and heart diseases, but this is not completely true.
Atrial fibrillation is a disease with a complex, multifactorial pathogenesis, and complex problems do not have simple solutions. This is why new, advanced, technically complex methods of treatment for atrial fibrillation are currently being actively developed around the world.
Medical technologies are developing rapidly. The cardiologists working in local clinics may quite often not be aware of the peculiarities of the latest methods of treatment. So, it would be worthwhile for them to meet in person those people who practice the medical techniques of the future.
Today, I will find out and tell you about the latest techniques of the surgical treatment of atrial fibrillation, one of the most frequent cardiological diseases. How do we fight atrial fibrillation in Russia? What have we achieved in recent years? And why each person suffering from arrhythmia needs a unique, individual approach.
Atrial fibrillation is almost always a chronic disease. To minimize its worrisome symptoms, prevent stroke or heart failure, timely treatment is of the utmost importance.
In this country, we have up to 70,000 ischemic strokes every year caused by embolism. Every second person here suffers from arrhythmia. Every second person. They just don't know about it. But this doesn't mean that all of them have to be patients and should be sent to the surgery. No. All they need is regular medical checkups.
Non-pharmacological methods of treatment of atrial fibrillation were first introduced in the 1980s. In those days, doctors assumed that the principal cause of atrial fibrillation was a disorder in the structure and function of the left atrium. But at that time, nobody knew the precise mechanism of this arrhythmia. Therefore, the left atrium was simply surgically isolated.
At that time, any cardiac surgery was very arduous and could have been accompanied by a great number of complications, some of them, unfortunately, lethal.
The maze procedure was performed for the first time in 1987. Technically, this is a very complex medical intervention, very traumatic for patients as well. But for doctors, such a surgery marked a paradigm shift of the view towards atrial fibrillation pathogenesis and treatment. About 20 years ago, minimally invasive catheter techniques of treating arrhythmia were introduced in clinical practice. It looked like the only viable technique of arrhythmia treatment, but in reality, this was not the case.
Catheter ablation still cannot assure a 100% success rate. We can assume 70 up to 75%. Some of the authors of this technique may achieve 80 to 85%, but this is not 100. You want to have a good result with catheter ablation? You need on average 2 procedures through the vessel. First surgery is 2 hours long, the second one normally 1 hour. But the patient can go home just after 2 or 3 days.
2018. Almost 4 decades have passed since the first surgical treatment of atrial fibrillation. Modern arrhythmology has a great number of techniques at its disposal that are able to treat this common disease. Each of the techniques has its own advantages and disadvantages, and every cardiologist in the country should be aware of them.
Nowadays, we have a clear understanding of which patients should be treated with a particular technique. Patients suffering from paroxysmal AFib are patients who require a catheter ablation. Patients with persistent AFib, or those who failed with or cannot be treated with catheter ablation, are the patients who need thoracoscopic radiofrequency ablation. Patients with AFib and other concomitant diseases should be treated through open heart surgery, maze procedure.
Today, I'm meeting the top specialists in our country in the field of arrhythmia treatment. These people are fighting arrhythmia every day, and they're winning. We will start with the introduction of one of the pioneers of arrhythmology in Russia.
Vishnevsky Institute of Surgery in Moscow, Russia. an open-heart atrial fibrillation surgery with cardiopulmonary bypass. This is called the Mays procedure. Historically, this is how surgical treatment of atrial fibrillation started.
So basically, we're ready when you are, Lyosha. Yes. Carotid compression. Ready for perfusion. I think we should perform filtration, right? She's a bit overweight, you know. Definitely. Okay, I can clamp it, right? Clamping the lower one. Clamping the upper one. Breathing is stopped, right? Okay with perfusion? Let's get around the pulmonary veins. We need to be careful here. It's a female heart. Very delicate. How old is she?
The female patient on the operating table is 66 years old. Her heart was stopped just a few seconds ago. Now only the cardiopulmonary bypass pump and Professor Revishvili are responsible for her life. Amiran Revishvili, academician of the Russian Academy of Sciences, professor, PhD, honored scientist of the Russian Federation, laureate of the USSR State Prize and the State Prize of the Russian Federation in Science and Technology, head surgeon of the Ministry of Health, general manager of Vishnevsky Institute of Surgery, pioneer of interventional arrhythmology in Russia.
Cross-clamping the aorta. Scissors, please. Starting cardioplegia, opening up the atrium. Can I have another one? Here, see? Now, in here. Do we have cardioplegia? Left vent, 200 millimeters, please. Here we're entering the right atrium. Here is the septum. Bloodless water should come from here and the heart should stop.
The aim of the Mays procedure is to create an artificial way for the native sinus impulse that is initiated in the sinoatrial node and travels through both atria towards the atrioventricular node. This can be achieved by excising the posterior wall of the left atrium and pulmonary veins, as well as multiple incisions through the atria, thus forming the so-called maze which the electrical impulse has to travel through, stimulating the myocardium. This procedure is called cut and sew.
Professor, what are we doing now?
Well, here you can see that the pulmonary veins are clamped with radiofrequency ablator device, and we're performing their isolation.
Today, the Mays 4 procedure is carried out, where radiofrequency current is used instead of classical incisions. Radiofrequency current is applied through the jaws of the clamp and forms a gentle necrosis, electrically isolating the area where arrhythmia occurs.
You see what we have here? Do you see that line of damage? This is where the electrical impulse no longer passes. Careful, careful. Don't tear it off. It's a female heart. A female heart, what does it like to do? It likes to spread out. This is quite a fatty heart. Normal thing for a woman. Not sure about all kind-hearted women, but this one is like this.
The Mays procedure is a very complex open-heart surgery in patients with a long history of atrial fibrillation, persistent and long-standing persistent AFib, or those with comorbidities and who require coronary artery bypass graft or heart valve repair. In the case of thrombosis in the left atrial appendage, the thrombus should be removed and the appendage should be resected to avoid recurrent thrombosis.
This is the left atrial appendage. I'm checking if there are any thrombi inside. Looks like there are no thrombi here. Here in these trabeculae, patients with atrial fibrillation have these thrombi. Right here.
The left atrial appendage, where thrombi may form, will be excluded from systemic circulation with suture during the Mays procedure. This will prevent the development of thromboembolic complications.
Well, you know, it depends on how experienced the surgeon is. If someone carries out hundreds of surgeries, he has a mortality rate lower than 1%. These operations are effective in 85 to 90% of cases.
In the last 25 years, 4 modifications of the Mays procedure have occurred. The latest does not require aortic clamping or the need for cardiopulmonary bypass. 25 years ago, this would have been considered impossible.
Everything is done on the beating heart. The left atrial appendage is either removed or electrically and mechanically excluded from the rest of the left atrium. Usually we achieve AFib termination in 90% of cases. Then we try to induce arrhythmia, and if we are able to do it, then we have 90% arrhythmia-free survival in the next 3 years.
Today, the maze procedure is performed only in 13 hospitals in Russia. According to Professor Revishvili, this is a very small number. It should be at least 10 times that.
Annually, we perform around 1,500 maze procedures, but we should operate on tens of thousands of such patients. Around 30,000 patients undergo catheter ablation of paroxysmal AFib, but around 200,000 patients need this procedure.
To do that, cardiologists should understand the indications for ablation in patients with cardiovascular diseases. These specialists must be aware of all modern methods of treatment.
We have a group of 5 atrial fibrillation specialists called the AFib team. But I think that a single person could make these decisions. One who knows pharmacological therapy, is aware of basic aspects of cardiology, and is able to perform catheter ablation, thoracoscopic, and open heart surgeries. And there are people like that.
But probably not a lot of them?
Well, let's count. Well, not too many, yeah.
Some think that surgery is the best way of atrial fibrillation treatment, that drugs are not effective. In the opinion of Dr. Revishvili, atrial fibrillation ablation should be performed in patients who experience symptomatic recurrences of AF despite antiarrhythmic drug therapy.
A patient comes to me and says, I didn't take my medication, I want surgery right away. The sooner you do it, the more effective it is. But I would still recommend pharmacological therapy as a first-line treatment. You may be surprised, but I have my own favorite medication which I've been recommending to my patients for almost 20 years. And for 2 or 3 years it's shown great results.
Professor Amiran Revishvili performs the maze procedure which protects the human heart from atrial fibrillation only in the most complex cases. But in the majority of cases, there is a way to treat arrhythmia without open heart surgery. The heart can be cured by less invasive methods as well. One of these methods is radiofrequency ablation. Moscow City Clinic Hospital number 23, named after Professor Davidovsky. The patient in the operating room is a 68-year-old man. Diagnosis: paroxysmal atrial fibrillation and atrial flutter. There is no effect of antiarrhythmic therapy, and catheter ablation is the only way to cure this patient. The procedure is performed by Farkhad Razayev. Farkhad Razayev, electrophysiologist, PhD, head of the Department of Complex Heart Rhythm Disorders and Pacing at the University Clinic of the Yevdokimov Moscow State University of Medicine and Dentistry, member of the board of the All-Russian Scientific Society of Arrhythmologists.
We are, as it were, performing 2 interventions, radiofrequency pulmonary vein isolation and cavatricuspid isthmus ablation. Since the right atrium is located relatively conveniently for radiofrequency ablation, I mean, we can get to the right atrium through femoral veins. We can easily reach the cavatricuspid isthmus in this case.
Radiofrequency ablation procedure, being performed by PhD Farkhad Razayev, is an elective intervention. The objective of the medical team is to identify triggered activity of pulmonary veins by means of electrophysiological study and to isolate them by radiofrequency ablation.
Right now, it reminds me of hunting. We're hunting for a specific electric potential.
By transeptal puncture, a diagnostic 10-polar lasso catheter that can identify local electrical activity is introduced into the left atrium. Then, an ablation catheter that supplies a radio frequency current to the source of the pathological impulse is delivered to the left atrium. The surgeon's objective is to electrically isolate pulmonary veins by means of radio frequency energy, which destroys cardiomyocytes that are replaced with connective tissue. This prevents propagation of electrical signals from pulmonary veins to the rest of the left atrium.
To induce atrial fibrillation, we need a trigger factor, meaning an electrical impulse that starts this arrhythmia. The triggers are located in the left atrium, in the area of the pulmonary veins ostia. We eliminate them during atrial fibrillation ablation. Now we see atrial flutter here. Here we can clearly see on the screen that we have 2 atrial electrograms, and only one of them can travel through the electroventricular node.
AFib ablation is guided by fluoroscopy, echocardiography, and atrial electrograms recorded by an electrophysiological station. The life of the man lying on the operating table depends on the surgeon's knowledge and skills.
This is a special needle to get there. We have our particular method of how to bend it. Yes, we see the root of the lung, and basically, the upper pulmonary vein goes along it. In principle, it's our reference point. I mean, we are targeting it. And in all three views, it should be exactly there. We put these needles through the introducer, but we do not pull it out. The tip stays there, and we descend to the area of the fossa ovalis. And we aim exactly at the root of the lung, which can be seen in different views.
During atrial fibrillation ablation, irrigated tip catheters with electrodes cooling are usually used. Electrode cooling is performed by flushing saline. This design prevents overheating of the endocardium, allowing sufficient energy delivery to achieve a large lesion size and depth and preventing thrombus formation. During the intervention, the operating team checks the level of the patient's blood coagulation every 30 minutes.
During 3 to 4 weeks before surgery, the patient receives anticoagulation. He definitely needs 3 to 4 weeks of anticoagulation before surgery. We need transesophageal echo or a CT scan to see if the left atrial appendage is clear. We should be sure that we don't have a thrombosis in there.
Pulmonary vein isolation and elimination of pulmonary vein triggered activity is the most important part of AFib ablation. The surgeon, to a large extent, is guided by electrical signals recorded by the diagnostic lasso catheter. The catheter is designed like a lasso that cowboys use. When inserted into the atrial cavity, it forms a tight loop and is positioned in the pulmonary veins ostia one by one. The loop of the lasso catheter has 10 pairs of electrodes that record electrical signals and send them to the electrophysiological monitoring station screen so that the surgeon can always see which pair of catheter poles record the pathological activity that should be eliminated.
You see, there's some noise on the screen. This is one more criteria showing that we are in the right place and that we will ablate pulmonary veins point by point. So you see channel 8, there was a potential there, and it has practically disappeared on lasso 8. I can adjust the position of the catheter and go to position 9. You see, now there's an active interference on lasso 9.
During the surgery, the patient is conscious. Only intravenous anesthesia and sedation are used. The surgery itself takes approximately 2 to 3 hours. Its effectiveness is up to 70%. This means that some of the patients that have undergone ablation will find themselves on the operating table again, but talk of further procedures can only be considered in 3 months.
If we perform repeat ablation in 3 months, the risk of complications is greater. Due to our intervention, in 2 to 3 days, there can be an arrhythmia, but it doesn't tell us anything. I mean, it doesn't impact the effectiveness in any way.
Surgeons call these 90 days a blanking period. First, as a result of the procedure, there is edema, and until it subsides, there's always a risk of recurrence. Second, during the post-operative period, patients receive antiarrhythmic and anticoagulant therapy. Only by the end of the blanking period can we conclude whether the surgery was a success or not.
There can be recurrences, there can be atrial flutter, and atrial fibrillation as well. But most of the time, we get a less clear result, and this is a very big problem. So-called silent atrial fibrillation. Basically, 2 to 3 months after the procedures, patients may have some asymptomatic episodes of atrial fibrillation that they do not feel, but that may be the cause of thrombosis. This is why anticoagulants are absolutely necessary during the first 2 to 3 months.
Radiofrequency catheter ablation can help most of those patients suffering from paroxysmal atrial fibrillation, though not instantly. In the relatively rare cases when RFA is ineffective, even if repeated 2 or 3 times in a row, then only open heart surgery can help. According to modern international guidelines, the maze procedure shouldn't be performed as an isolated surgery, but only in combination with other cardiosurgical interventions. The problem of atrial fibrillation relapses for the patients with large left atrium and long-standing persistent atrial fibrillation can be solved by use of a less invasive but no less effective operation than the maze procedure, a thoracoscopic RFA.
Thoracoscopic ablation is a minimally invasive surgery used to treat atrial fibrillation. Basically, this is a compromise between the maze procedure and catheter technologies. During radiofrequency ablation, the openings of the pulmonary veins ostia are isolated not from the inside, like during catheter procedures, but from the outside with the help of endoscopic tools.
In Russia, only a small number of medical institutions are able to perform such a procedure, like the Clinical Hospital of the Administrative Directorate of the President of Russian Federation.
In our country, Oleg Pidanov has become the pioneer in this field. Oleg Pidanov, PhD, cardiovascular surgeon, doctor of the highest category, member of the Cardiovascular Surgeons Association of Russia.
Basically, we're doing the same maze procedure, but for this, we use very sophisticated equipment. We use endoscopic tools and radiofrequency energy. We create ablation lines, controlling it visually, without fluoroscopy. Therefore, we can actually achieve high effectiveness for those patients with long-standing, persistent AF, with less operative trauma.
Thoracoscopic ablation is carried out through two tiny punctures made to the thorax. It is much safer in comparison to the open-heart cardiosurgical procedures, but complications still may occur after thoracoscopic ablation, though they are not frequent.
The most difficult to treat and dangerous complication during the thoracoscopic procedure is the heart perforation. This complication occurs in about 1% of cases. This means that in order to stop the bleeding, you need to perform a sternotomy. You have to perform a serious surgery to stop the bleeding. Of course, this is unpleasant for both the surgeon and the patient, but it is needed in order to save the life. Taking into account the risk of complication, it can be placed between catheter procedures and open surgery. That's the balance.
Including the preparation and anesthesia, thoracoscopic ablation takes about 2 hours. If patients have complex anatomy, then this may take around 3 hours. As with the maze procedure, the left atrial appendage is sutured during the surgery to avoid thrombosis in the future.
The left appendage should be resected. But this is not just a mechanical exclusion, but also an electric isolation from the rest of the heart. So, by eliminating the left appendage, we increase the effectiveness of our atrial fibrillation treatment as such.
Rehabilitation after surgery takes several weeks. The patient spends the first 24 hours in an intensive care unit. Then the drainage is taken off from the pleural cavity and the patient is transferred to a hospital ward.
Usually the same day or the next day, the patient can get dressed and start walking around the ward. But let's be honest, someone who has just undergone surgery is bound to suffer from weakness or pain, and it may last for up to 4 to 5 days. If it's not an elderly patient, then in 5 days, this patient can be released from the hospital. But it's not like he's allowed to disappear somewhere into the wilderness. He should definitely stay under supervision of a cardiologist.
Thoracoscopic ablation is just one of the many modern methods of treating arrhythmia, a method that has its pros and cons.
There are specific medical indications for this surgery. These are patients who are refused by an interventional cardiologist who says that their heart is too big and there's nothing he can do. Then the so-called thoracoscopic technology comes in. Usually, 3 to 4 months later, this patient still needs to see an interventional cardiologist, and he should check how it was made from the outside and what it looks from the inside. He should map the heart to determine if this scar, for example, is fully circular or not, and if there are zones where the impulse can still travel, and should be isolated with the help of ablation.
If patients suffer from atrial fibrillation, then turbulent blood flow, inflammation, and hypercoagulation may cause thrombosis. Thrombi, break-off, and subsequent embolic stroke are the most dangerous complications of arrhythmia. 12 years ago, Russian cardiologists for the first time carried out our surgery, left atrial appendage occlusion. This allows us to exclude it from the systemic circulation.
Myasnikov Institute of Clinical Cardiology of the Ministry of Health of the Russian Federation. It was here in 2005 that the first endovascular atrial appendage occlusion was performed. Dr. Yevgeny Merkelov was the man at the forefront of this unique approach. Yevgeny Merkelov, a vascular surgeon, PhD, head of the endovascular surgery department of Myasnikov Scientific Institute of Clinical Cardiology.
It's clearly shown here what we should achieve with the help of our tools. Here's the left atrial cavity. After transeptal puncture, we deliver the device that is implemented into the left atrial appendage. You should notice that unlike the left atrial wall that is smooth, the left atrial appendage has trabecularity, and the thrombi are easily formed in these trabeculae. Left atrial appendage contractility is very low. This causes blood stasis and formation of thrombus. Our objective is to isolate its cavity from the left atrium. The device is deployed within the left atrial appendage and is fixed there by means of small anchors. After some time, approximately 45 days, gradual endothelialization takes place as shown here. All we can see now is a small part of the left atrial appendage, but not its cavity. Here you can see for yourself. We have a simulation model here. Take this. This is a catheter which should be delivered to the left atrial appendage cavity. After that, we gradually release this device.
So it is just folded, right?
Right, it's folded and is ready for implantation. Our task is to choose the right size of the device and to release it exactly in the right place. Here it starts to unfold slowly.
So it unfolds by itself?
Yes. And then it jumps to the exact place and fixes itself there. Also, see here, on the dome, there's a special membrane that doesn't let the blood in and is easily endothelialized later. And these are the anchors that secure the device and prevent it falling out.
During the left atrial appendage occlusion procedure, the surgeon uses fluoroscopy and transesophageal echocardiography. The transeptal puncture should be very precise. Before the procedure, the patient undergoes a CT scan to examine left atrium anatomy and rule out intraatrial thrombosis. If there are thrombi in the left atrial appendage, anticoagulation is required and the surgery should be rescheduled.
Here we have a very good illustration of how dangerous thrombosis is for patients suffering from atrial fibrillation. This is the left atrial cavity. Here's the left atrial appendage, this small structure here. This patient has a thrombus, and that thrombus started to grow and grow to the extent that it protruded into the left atrial cavity and started to float. It's obvious that even if just a small fragment of this thrombus breaks off during cardial contractions, it will travel to the brain and a severe stroke will occur, most likely not compatible with life.
The occluder that gradually blocks the access of blood flow into the left atrial appendage should be chosen according to the anatomy of the patient. The diameter of the device is correspondent with the inner diameter of the appendage.
Here is this device. When it's unfolded, it will be approximately the same size as the appendage. It's important there is no residual flow. The membrane itself will gradually stop letting the blood through.
The gold standard for the prevention of thromboembolic complications is pharmacological therapy. However, some patients cannot take anticoagulants for long periods. For example, due to a high risk of bleeding. For such patients, endovascular left atrial appendage occlusion is the only method to prevent stroke.
It is possible to combat atrial fibrillation by sending electrical impulses into the surgical maze. In many cases, arrhythmia can be overcome with the help of catheter ablation. Also, you can isolate pulmonary veins by using cryotechnologies. We will see now how it happens.
Medical Research Center of Preventive Medicine. Performing the operation is Karapet Davtyan, MD, PhD, cardiovascular surgeon. Karapet Davtyan, PhD, head of the Radiology and Endovascular Arrhythmia Treatment Department, cardiovascular surgeon, PhD.
For this procedure, we perform transeptal puncture. We go through the interatrial septum. Here are the veins, where we deploy the Achieve mapping catheter with electrodes, which is very soft. You can see the flashes. This means there's arrhythmia. We use a balloon to prevent mechanical damage of the heart. So, while inflating the balloon, see? we can totally occlude and block the pulmonary vein ostium. A contrast media is injected, and we see that it doesn't leak into the left atrium. This means that we have a contact. It is very close. So after this, cryoablation begins. In such a situation, the blood does not freeze because it is warm. It flows through. We freeze only the areas where the balloon is in a maximum contact with the left atrium. And after we deflate the balloon, we obviously can see the marking line and these flashes that don't move toward the atrium anymore. They stay in the pulmonary veins. This is atrial fibrillation as it is, isolated in the place of its origin.
Here is a female patient with atrial fibrillation, about to undergo a balloon cryoablation procedure that will preserve her heartbeat and health. This procedure is performed under local anesthesia. Using a special sheath, cryoballoon filled with liquid nitrous oxide is delivered to the pulmonary veins ostia.
The duration of cold exposure is about 4 minutes. We have positioned the balloon and start the injection of the contrast agent. Let's inject it now. Excellent. We can see that the contrast is not leaking out from the vein. We have prevented a leak from the vein, which indicates our contrast is sufficient and we can start freezing.
The surgeon's task is to cool, or rather to freeze, parts of the heart tissue in the area of the opening of pulmonary veins to prevent propagation of electrical impulses from them.
Did you see that? In less than 4 minutes, I've finished isolating the vein. That's it. It is not there anymore. The problem is solved. We're inflating the balloon again.
Cryoballoon placed in the ostium of the pulmonary vein will freeze and kill heart tissue. As a result, the electric impulses that cause the heart to contract irregularly will not be able to travel through this area of electrical isolation and excite either the left or the right atrium.
This is one of the patients who will have our loop recorder implanted. Let me show you what it looks like.
It's like a flash drive.
It's the size of a flash drive. My assistant will help me here. She'll be controlling the frenicus. And I will move upwards, trying not to lose these 4 minutes. I'll try to place the recorder in the intercostal space so that there's no contouring.
The device Karapets-Davtyan is speaking about is a heart rhythm recorder, which is implanted under the skin of the patient's chest. The built-in battery can last up to 3 years, whilst the recorder reports the whole truth about the heart rate.
No matter if you're sleeping, walking, running, or jumping, whether you feel any heartbeat irregularity or not, the device will record everything.
4 minutes, more than enough for the heart tissue to stop conducting electrical impulses. As a result, one of the major factors in the pathogenesis of atrial fibrillation will cease to work, and there is a chance that the patient will be cured of arrhythmia.
When a patient is diagnosed with atrial fibrillation, he only has 2 options. Either to develop, slowly but surely, chronic arrhythmia, or to jump on the departing train which is heading for these intervention procedures. Unfortunately, there's no other option for the patient.
Annually, over 300 cryoballoon isolation procedures are performed by Professor Davtyan and his colleagues at the National Medical Research Center for Preventive Medicine, and they also tutor their colleagues.
This balloon has a very complex structure to make it as safe as possible for the patient. There are 2 layers here, synthetic polymer. There are pressure sensors between the layers, and the pressure inside is negative. So, if the inner or outer layer is damaged, the system itself will suck in gas swiftly to avoid air embolism.
Clever device.
Yeah. We'll put it here right now. Okay. Let's inflate it. See how it's inflating?
Please.
Now freezing. Now let's cause some damage to it. Let's say it's torn. What will happen then? We don't trust the appliances, right? Here. See these blocks of ice here? They're cracking. Now we cause damage to the balloon. That's it. The system is halted. It sucked in all the gas, see? The ice is still here. Traces of ice. But the balloon is gone.
Cryotechnology is not just a new technique, It's an innovative technique, even if compared to the radiofrequency ablation. This is why surgeons compare them to each other quite often.
If we talk about percentages in clinical trials, both approaches suggest effectiveness of 60 to 70%. But there is one but here. When we look at studies concerning radiofrequency ablation, they suggest this effectiveness after 1, 2, or 3 interventions. So the number of procedures is not that important. When we take the research on the cryo, we have only one surgery here. So we see that cryoablation after one procedure is just as effective as radiofrequency ablation after 2 or more interventions.
Catheter technology is a huge step forward in the treatment of atrial fibrillation, but the downside here is that during the procedure, both the electrophysiologist and the patient are exposed to radiation. It is possible to greatly reduce it with the help of left atrial ablation by means of 3D navigation mapping.
National Pirogov Medical Surgical Center. Catheter ablation with 3D navigation mapping performed by cardiovascular surgeon Artyom Sveshnikov. Artyom Sveshnikov, PhD, cardiac surgeon, head of the Department for the Surgical Treatment of Complex Heart Rhythm Disturbances and Pacing of the Pirogov Center.
Tatiana Valentinovna, remind me please, how old are you?
I'm 49.
49? That's no age at all.
The female patient on the operating table underwent a cryo-balloon ablation 6 months ago, but arrhythmia was not cured. According to the statistics, this happens in 30% of cases.
Most likely, it was due to the fact that at some point the balloon didn't completely occlude the pulmonary vein, and the vein is not perfectly round. It probably has an irregular shape. Usually closer to the upper or lower pole, the balloon doesn't entirely fit the vein. This results in formation of areas that are badly frozen.
Further ablation usually is more complex than the initial one, as for example, there may already be a scar tissue in the area of transeptal puncture. After ineffective cryoablation, the technique should be changed. Now this is a radiofrequency ablation with navigational mapping. First of all, the surgeon creates a 3D map of the left atrium with the help of a special catheter.
I'm trying to create as detailed a 3D map of the left atrium as possible. Later, it makes work easier if the mapping coincides with real anatomy.
The catheter Artyom Sveshnikov is using is a very complex technical device. Saline is being delivered constantly to the area of ablation through the 6 small openings. It prevents the tissue from overheating and as a result reduces the risk of thrombosis and increases the depth of damage. Several sensors are built into the tip of the catheter.
There are several sensors on the tip of the catheter. A pressure sensor, a temperature sensor, and a 3D magnetic location sensor. There are poles on each of the 3 3D coordinate axes which record electrical signals. There are also openings through which saline is supplied.
Next, using the catheter, which can register electrical impulses in the pulmonary veins ostia, ablation of the problem areas with predefined design is performed.
So we've started radiofrequency ablation. I've got 23, 24 seconds, see? In the left corner there's a timer. 27, 28, 29, 30. Now it's stopped. Moving on to the next location. We call it point by point. You can see it very clearly now on the right electrophysiological monitor. Electric activity due to atrial fibrillation. The more we stay here, the more each of the dots there become more of a bright red color.
Thanks to the 3D navigation, the X-ray station will be turned on only from time to time, thus decreasing the radiation exposure to the surgeon, his team and the patient. Another huge advantage of this is maximal level of visualization.
I want to draw your attention to the right screen of the monitor. Here we have activity in the pulmonary veins ostia recorded before the radiofrequency ablation. You can see activity exactly in the pulmonary veins ostia channels 6, 7, and 8. The right part of the screen shows no activity at all. This means that we have performed a complete and high-quality isolation of pulmonary veins.
There are 6 major non-pharmaceutical methods of treatment of arrhythmia and its complications. Each of them may, to a greater or a lesser extent, suit one or another specific patient. Only the surgeon can make the choice and the patient themselves.
American doctors keep telling me, you're the only one who is against the group of 5 to 6 professionals where the main chair is occupied by the patient who is listening to all of them. And I'm saying, you just don't get it. The patients do not have the proper medical education. Every one of you is a leader, yes. Everyone defends his own point of view. But how can the patient know who he should trust? When there's a doctor-patient one-on-one situation and the doctor has the patient's confidence, then patients start to trust the doctor and it's easier for them to make a decision.
Arrhythmia is not dangerous by itself. What is dangerous? The complications that accompany it: thrombosis, stroke, heart failure. It can make a disabled person out of a healthy one.
The situation is catastrophic, of course, because the damage caused by ischemic strokes resulting from fibrillation is much greater than that of other types of ischemic strokes.
Atrial fibrillation should definitely be treated. All surgeons agree on that. The methods of how to cure atrial fibrillation may be various, but the objective is the same. And to achieve this objective, they work, so to speak, their fingers to the bone.
Preventing arrhythmia, maintaining the right sinus rhythm that God gave us, is our main goal. I think that arrhythmology should be an independent branch of medicine in its own right. A central clinic for arrhythmology should be established, or at least one major research center in our country. It's obvious that we need not just 60 clinics, we need 3 or 4 times that much. And we need financing for this, of course. It's not too expensive, considering the fact that 95 to 97% of the patients become socially active again.